at Fair Oaks, and I rounded on the weekends at Fair Oaks as well. So my interest is in heart failure and valvular disease. I do a lot of research as well in cardiac diseases. So it's, again, a pleasure to be here. I'm going to launch a quick poll to see if this thing works. Let's start with a simple question. Do you see the first question? Where do you primarily work at? Or do you see all the questions at the same time?
We see all the questions at the same time.
Okay. Can you just answer the first question and see if this works? All right. I'm going to end the poll. Let's see. Share results. Huh. Nothing came through.
It wouldn't let us click on an answer.
Let me relaunch it.
I think it wanted you to answer all the questions at once.
Oh, maybe.
Really? Okay. Do you see?
To submit. I can see them all.
You can see them all?
Mm-hmm.
Can you click any answers?
You can click them, but to submit, you have to answer all the questions.
Oh, really? Oh. That's a bummer. How about this?
My answers came through there, so I'm good. I can see my answer on your screen.
Oh yeah, I see that. You took a guess at the other ones. Okay. Well, why don't people just answer the first three, and then I'll relaunch the poll for, questions 4, 5, and 6 later. How about that? Can you all submit?
Send it again, please.
Send it. Oh, I think it's still open though. Okay, a second person just answered.
I had to select an answer for the other three. I just guessed and
yeah, I just guessed on the other ones. That's fine. I just will kind of get a flavor of where everyone's at. Okay, 4 people. So far, half Fair Oaks, half Fairfax. Wow, most people with more than 10 years experience. Everyone went to the beach for vacation. Anyone else? Okay. All right. Well, thanks for doing that. I'll relaunch the poll. Maybe I'll duplicate this. Okay. All right. So I'm going to talk about common cardiac issues, and there'll be a couple of questions to kind of keep it more interesting. Let me share my screen. Hopefully this will work. Let's see, video, this. I'm going to share my presentation. Okay, can you see my presentation? Yep.
Yeah.
Okay, great. Okay, so common inpatient cardiac emergencies. These are my disclosures. So, I do site-based research for several companies. I do own some stock in Edwards, which makes the TAVR valve, and I've been an expert witness for defense. So the goals today, I'll just go over normal cardiac anatomy and physiology. We'll go through some cases, and then we'll do some question and answer after that. Okay. So heart disease. So, when I talk about heart disease to patients, they say I have heart disease, but it's a very broad word to say. Like, so what is heart disease? Like, what part of the heart is affected, right? And so I break it down to basically one of 4 areas. So you can have problems with the pipes, right? So people can have blockages in the coronary arteries, and that's where they get heart attacks. Sorry, not heart attach, but heart attacks. Then you can have problems with electricity. You can have problems in the conduction system, which may require pacemakers, or you can have arrhythmias like AFib, which can cause strokes. And then I'd say, are there problems with the doors of the heart, right? There are 4 valves in the heart. You could have either regurgitation or stenosis. And then the last part is the heart's a pump. And so if you have ventricular problems, systolic problems, then that is heart failure. And then to make people feel better, if they have problems with all 4 parts of the heart, then there's a pericardium, and most people have a good pericardium, right? So, but of course, you can have pericarditis and you could have pericardial effusions, and that can cause tamponade. So just a quick review. So the heart here has 4 chambers, right? Deoxygenated blood enters right atrium, crosses the tricuspid valve, goes into the right ventricle to be pumped through the main pulmonary artery, and it branches into the right and left pulmonary artery. Then it comes back via 4 pulmonary veins to the left atrium. And the left atrium, the blood crosses over the mitral valve into the left ventricle. This is the muscular chamber that then pumps blood through the aortic valve into your aorta, which goes to the body. So that's the main circuit. When we talk about heart attacks, we're mainly talking about heart attacks that are affecting the left ventricle, and there are 3 arteries that supply that. Though you can have an RV infarction if you have a blockage of the right coronary artery right at the beginning. A proximal RCA can cause our RV infarction. But by and large, when we talk about heart attacks, we're really thinking about its effects on the left ventricle. Here is a picture of an echo to show you what we see. This is an apical 4-chamber. This here at the top is the left ventricle. So it's kind of inverted, right? So left is on the right, right is on the left. And therefore, to help you image, this is what it looks like here. So this is the left ventricle. Here you see the mitral valve opening and closing with diastole, and closing with systole. This is the left atrium. This membrane is the interatrial septum. 10 to 20% of the people have a tiny hole in the heart. That's the patent foramen ovale, or PFO. Over here, you have the right atrium. Here you see the tricuspid valve. This is the right ventricle. And you can see that actually the right ventricle actually looks smaller than the left ventricle, but the right ventricle is like a croissant that kind of wraps its way around the LV. So technically the right ventricle is larger in volume, but on echo, we just get a weird slice of it. So it does look smaller, but in actuality, it's slightly larger. And then in the middle here is the interventricular septum. So that's what we see on echo. And just to stay on echo, echo is ordered quite a bit for patients. And when I read an echo lab, I see repetitive echoes on people almost every 2 or 3 days sometimes. And I just want to clarify what echo is good at and what it's not so good at. So echo is very good at defining ventricular function, valve function. And actually, echo, when it first got started off, was really validated based on its utility with pericardial effusions and defining tamponade. And here's a crazy image of a pericardial effusion with tamponade. You see this big black space here. That's a huge pericardial effusion. And you just see the heart kind of swinging back and forth in the chest. And that's because when you under tamponade, that whole area is so filled with fluid that the heart no longer can expand normally. Right? It's like a heart is just trying to take up some space in a very tight pocket. And so when the RV expands, the LV shrinks. And when the LV expands, the RV shrinks. So this is called ventricular interdependence, and that's what's causing that swinging motion. And so this person is in a very bad situation, and this needs to be urgently drained to relieve the tamponade. Okay. Down here, this is a great image. Again, this is the left ventricle. This is the LA. This is like a 2-chamber view. And with color Doppler, we can see regurgitation. So this is severe mitral regurgitation here. Okay, so echo, really good at tamponade, really good at looking at valve function, good at looking at ventricular function. Oops, sorry. Oh, how do I go back? Sorry. Actually, go back here. What it's not so good at is, acute coronary syndromes. We can see some focal wall motion abnormalities. But, in an acute STEMI, things are really dependent on what the EKG looks like. And then what it's not so good at is arrhythmia. I mean, yes, we can see if someone's an AFib during an echo. But it's, it's not the best at defining arrhythmias or PVCs or finding the origin of PVCs or things like that. So that's a little about echo. So moving on to a little bit about anatomy. So there are 3 major arteries that supply blood to the ventricles. The most important starts here with the left main, and then that branches into the left circumflex, which kind of goes underneath the armpit, and it wraps around. And then the quote unquote widowmaker, I hate that nickname, but that's what a lot of patients know it as, is this LAD, the left anterior descending, which goes straight down the anterior part of the heart and it wraps around the apex. And then on the right, you have the right coronary artery, which does supply a few branches to the right ventricle. And then in most people, it wraps around and supplies blood to the inferior and the posterior wall. So the 3 arteries, again, are the LAD, the circumflex, and the right coronary artery. Okay. And so what is a heart attack? So, the basis of coronary artery disease is the accumulation of this yellow stuff, which is cholesterol. And that's the atherosclerotic process. And, really actually as a late teenager in your 20s, you can start developing what is called a fatty streak. And that's a misnomer because it's actually not fat in the wall. It's cholesterol. Cholesterol isn't fat. Cholesterol is a waxy substance, but they do call it a fatty streak. But, if you start having early disease, maybe due to diabetes or smoking or a bad family history, what happens is in the 3rd or 4th decade of life, you will start accumulating cholesterol plaque. The plaque is actually embedded within the wall. And what I tell patients is, you've heard of black mold and drywall, right? Like some houses are infested, but when you walk into that room, you just see drywall. You can't tell there's black mold unless you drill a hole. The same thing from the interior, you can start accumulating cholesterol into the wall. The blood flowing won't see it. It's happy. It's not really seeing anything. It's only when there's a rupture, when there's a crack of that cap, that you get exposure of cholesterol with the bloodstream, and that creates a thrombosis. And that's what this picture here is showing you, right? So you have at the top an unobstructed artery with nice blood flow. The middle picture shows what would be a severe obstruction because the lumen is now narrowed to be less than 70%. And this person may experience angina with exercise, or they may not. But what happens is in midst of a heart attack, you get a fracture of that cap, and then suddenly you get exposure of the cholesterol, and that creates a clot. So a heart attack really is a 2-step process. First, you have some accumulation of cholesterol, which may take decades to do. And then suddenly at one point you'll get a fracture, and that creates a clot, and that clot formation can occur in seconds. Okay. So it's a slow process with a very rapid event that happens. Another thing that I want to press upon everyone is, if you look in this diagram with this severe plaque here, traditionally we used to think the majority of heart attacks happen with severe blockages. But what we now know is actually less than 50% of heart attacks are due to a severe blockage. The majority are actually due to either a minor, mild plaque or moderate plaque. And so when we do stress testing, like a stress nuclear or treadmill stress test or stress echo, we can only really pick up severe blockages. So that's why with nuclear stress tests, we say, oh, actually blood flow is fine. We don't see anything bad. But those people can still suffer a heart attack because we're missing a mild plaque. We're missing the moderate plaque. So the question is like, well, what's a better screening test? And, just for everyone on the call, I would suggest if you're over age 40 or postmenopausal, you should consider getting a calcium score. Because after age 40, 45, most people, if you do have any element of cholesterol deposition, your body will put little bits of calcium in there to kind of stabilize it. We actually now know that the calcification in the plaque is actually a stabilizing process. right? But when we scan the heart and we see some calcium, we can say, aha, there must be cholesterol there. So the calcium is a proxy marker of how much cholesterol there is in the arteries. And we have charts that can say, okay, if you're like a 55-year-old woman, this would be an average score. And if your calcium score is higher than that, then that would say, well, for women your age, you actually have higher risk. So a calcium score is nice and cheap. It's not covered by insurance, but it's like usually $100 or so, but it's a good screening test. So that's my public service announcement for the group here. So I've had 2 calcium scores already, both zeros. So I've been happy. Anyways, moving on. So what does a cardiac catheterization look like? So maybe for some of the older nurses, you may remember a lot of femoral artery access and people coming with a clamp on their, femoral artery, and they can't move for hours at a time. By and large, the majority of cardiac catheterizations these days are done through the radial artery. So a good institution like Inova, more than 75% of the time, we are able to access the coronary arteries through the radial artery. So that's a high quality institution. So, if you insert from the radial artery, you go through the brachial, come back to the arch, and you can get into the coronary arteries that way. Accessing through the radial artery is a much less risky procedure. The incidence of bleeding is a lot lower. And should you bleed, obviously you have much easier control here at the wrist rather than at the thigh, where you can bleed quite a bit into the retroperitoneum or into the thigh. So it's a much higher quality, lower risk procedure. So, So going back here, sorry. So just to give you what we do on the cath lab, the patient's laying on the table. We have a C-arm overneath them, and it's just a giant X-ray machine with fluoroscopy. And we engage the artery with a flexible, soft catheter, and we inject iodine contrast. And you should see the whole artery kind of outlined all the way to the distal circulation. And if there's a filling defect anywhere, then that's either an acute thrombus or a plaque. So this here is the right coronary artery. This here on the right is the left main here, which branching is into the circumflex and the LAD. Okay. I just got a message from Jen Fabian. Thank you. Wondered why our patient said they had negative stress tests and it larger. Yep. So a nuclear stress test can miss quite a bit. Anyways, going forward, so what does a stent look like? So people always think about, oh, can't you just rotor-rooter out the plaque? That isn't what really happens. So the cholesterol plaque is basically just compressed and pushed to the sides of the wall with this balloon, and then we leave in its place this stent. So all that cholesterol that can generate thrombus is actually still there. And that's why long-term treatment with aspirin and statin is so essential. That's actually what really saves lives. It's the aspirin and the statin. The stent in midst of a heart attack is just to recreate the channel, get through the clot so you can restore blood flow. Okay. So there's no sucking out of cholesterol. There's no rotor-rooter action. Another analogy, if you have kids and they have a dirty room and you tell them to clean the room, if all they did was like push the dirty clothes to the side to create a pathway, you wouldn't consider that room to be clean by any means. So that's what really happens with the stent. You're just pushing the atherosclerotic plaque to the side. Jen asked, well, what's during atherectomy? What do they do? So what happens in atherectomy is, yes, that is a little bit of rotor-rooter. So sometimes the plaques are so calcified or they're at weird angles that you can't really deploy the stent. The stent won't bend that way. So you do use a burr to kind of bore out a channel. However, you're not really clearing out all the cholesterol. You're just creating a smaller channel, and you're denuding the interior of the artery, the endothelium, that covering that I talk about that gets fractured. Well, you just carved out all the endothelium. So atherectomies actually they're like, a bad thing that you have to do sometimes to deploy the stent. And that's why in those patients, doing antiplatelet therapy is very, very important so you prevent the thrombosis. So yes, atherectomy do exist, but again, you're not clearing out most of that cholesterol. You're just clearing out just a small channel to get your stent through. And we only do that when it's absolutely necessary. We try to avoid it. Okay, so next point I want to talk about is EKGs are so important. And I just want to reiterate that unfortunately, I still see EKGs done incorrectly quite a bit, and we'll get into why that's bad. Because it can create distortions and artifacts and create abnormal readings. So just want to highlight that V1 and V2 go on either side of the sternum, and they really should go in this fourth intercostal space, which is really low. And what I often see is that people put the V1, V2 really high up here, like almost near the clavicles. And that's not good because that makes it hard for us to discern the P waves because the atrium in your heart is here, right? So that's why you want to put your V1, V2 really low. And the higher up you do it, the farther away you are from the atrium, you're going to decrease the voltage of the P wave. So that kind of makes it harder to interpret. And the other thing too is V3, V4, V5, V6 really should be following the fifth intercostal space. And in men, you can use the nipple as a good landmark because V4 should be right underneath there because that's your midclavicular line. And V3 should split the difference, or it should be right in the middle between V2 and V4. V5 and V6, really high quality. You should really go really lateral, and that V6 ideally should be right, mid-axillary, right underneath the armpit. Unfortunately, I often see in women that the leads are put kind of over the breast, and not the breast isn't lifted, and it's not put along the thoracic wall. And when you don't do that, you create distortions in the R wave progression. So, I know everyone wants to be quick, and some people don't want to hassle women too much if they have a bra on, but especially if someone's complaining of chest pain or there's a question of arrhythmia, it's really important to put these leads V1, V2 low, and then please put the leads underneath the breast in women. So another request, that'd be good. I'm going to stop here. I covered quite a bit of like basic physiology. We're not a super big group, so if anyone wants to jump in with any questions, I can pause here or go back to any slides. Oh, I see Carrie online. Hey, Carrie. So,
Hello.
oh, hi. Thanks for jumping
I was
on.
actually going to ask. Oh yeah,
Yeah.
no, thank you. We got the invite a little late, but I see it's being recorded, so maybe we can share it with the team.
Oh yeah.
But would you say at Fairfax, especially, that we might see, like you talked about the atherectomy not being, ideal? Would you say we see more of those higher risk procedures, and it's not necessarily, nationwide, or maybe at
Yeah.
smaller facilities, not typically done as much?
Yeah, definitely. I mean, I think, we are a high risk PCI center. So obviously, cases are transferred from Loudoun or other institutions to do high risk PCI. And of course, in some of those cases, we have to do like a burr atherectomy. So yes, we do more atherectomies than typical. That being said, like, I don't think we overuse atherectomy. I think we just unfortunately have a high risk population that require it sometimes. But yeah, you don't want to do an atherectomy unless you really have to, because it does, denude that endothelium. So, yeah, I mean, that's just like part of the high risk to do it. Yeah. But, again, we do a lot of radial approach. And to be honest, like Fairfax was a little bit slow on that uptake. I mean, I think other institutions started doing radials really starting like 2007, and I think when I came to in 2012, I think we were still majority femoral approach, but pretty rapidly, I think by 2016, 2017, we became majority radial, and now we're very strong in radial. So I think, as doctors, doctors don't like learning new things, and the way they did it in training kind of persists. And I think it took somewhat of a cultural shift to do it. But by and large now, I think you should be seeing a lot of radial approaches. And I think because of that, you should also be seeing less major bleeding. And, outcomes after stenting really follow bleeding risk. So if you reduce bleeding, you improve outcomes quite a bit.
I have a quick question about
yeah.
SCAD. So when you're diagnosing SCAD, is that something you can see when you're shooting the dye in the cath lab, or basically are you just seeing that the coronaries are clean, and
Yeah.
yet they had an STEMI?
Yeah, great question. So just to highlight, so SCAD stands for spontaneous coronary artery dissection. It represents somewhere between maybe 4 to 8% of all myocardial infarctions. It is more common in women. It is related to a disease called fibromuscular dysplasia. So SCAD is basically a spontaneous dissection of the coronary artery due to what we think is a rupture of the vasa vasorum. So the arteries, even though they carry blood, have their own separate blood circulation to maintain the tissue. That's the vasa vasorum. And so that could be ruptured spontaneously. We think it's related to estrogen because it's more common in women. We do see it in postpartum women. So a classic story is if you have a young pregnant woman who's like 30 that has severe chest pain after delivery, has SC elevation, that would be a spontaneous dissection of the artery. So, progesterone and estrogen create laxity in the tissue, and we're still unclear about why that is or how that is, but it causes more ruptures. So the way that we see SCAD is when you do engage the arteries and you inject, then you'll see what we'll call blushing. You'll see that there is dye staining in the artery that persists a little longer than typical. And that is the dye being stained in the dissected area. And what you do is nothing. That interventionalist should not put a wire down. You don't try to engage it. You just disengage and you leave that person on heparin drip for a couple of days. And that usually what happens is that will start healing on its own. And usually people aren't really left with severe stenosis after that. So the less you do is the better for SCAD. And then, of course, then you should totally scan that person for fibromuscular dysplasia. You should look at their carotid arteries. You should look at the renal arteries. Really, you should do a head-to-toe evaluation to make sure there's no other stenosis. This hits close home because one of my research nurses, who is the picture of health, true story, she came to me. She's like, my mom had some carotid disease. I just want to be sure. So I did a calcium score on her, and she was in her mid-60s, and it was 0. And I said, listen, you are totally fine. You don't have any cholesterol in the arteries. And she felt reassured. And sure enough, on Thanksgiving Day, she was waiting for dinner and started developing not even chest pain. It was base neck pain, really right here. And she felt really short of breath, never had it before. Came into Fairfax ER Thanksgiving evening, had lateral SC elevation, went to the cath lab, and she had SCAD. She didn't have any atherosclerotic disease. So the calcium score was correct, but she had a SCAD. And then further investigation, she had fibromuscular dysplasia. So this stuff really happens, and we see it a lot in women. So it's something to be aware of. So that's a great question.
Dr. Tran, is there anything different that you have to do from a radial approach for your access for the catheterization? I mean, I would imagine a smaller catheter would be needed, but is there more difficulty in passing, like through the arch or anything, to get to the arteries?
Yeah, sometimes you can. So the catheters for radial approaches are different than the femoral. The catheters have different angles, and they are smaller caliber. When you enter the artery, we do. It sounds crazy, but it's called a through and through approach. You put a needle from the top part of the radial artery, and you go through the radial artery to the other side. Then you pull back into the lumen, and then you push in your catheter. So it's a through and through. So you're puncturing it twice. And then we inject some lidocaine, and we inject some vasodilators, because sometimes you can get vasospasm in the radial artery. So sometimes as you're traversing the radial, the whole thing can spasm down, and you just have to wait or give more vasodilators and try to get through the brachial artery. Sometimes what happens too is when the brachial artery goes into subclavian and then you enter the arch. Sometimes it can be like a little like loopy, and you can be difficult to pass. And a simple trick is you can tell the patient to inhale and exhale, and that process you can actually cross through the arch into the aortic root. And there, the techniques are a little bit different to engage. But most of at this point, all the interventions are very facile with it. So yeah, the catheter is slightly different. The approach technique is a little different. But again, we're seeing great results with it. So, the whole field has really just gone radial first.
Thank you.
Yep.
Looks like Anna might have a question too.
Yep.
Yes. So back when you were talking about the reason for doing the calcium score is that your body, can you just re-explain that a little bit, how your body puts out more calcium to help stabilize some of that plaque?
Yeah.
Is that correct? Okay.
Yeah, exactly. So the atherosclerosis, I should say, how about this? Atherosclerosis is an inflammatory process. We now really understand that. Like the deposition of cholesterol into the artery is due to inflammation and causes local inflammation. And in the field, like now we're using colchicine. We're finding that colchicine post MI is actually helpful in reducing recurrent events. So reducing inflammation is a whole field now. And so the body tends to put calcium in inflammatory areas. And in some areas, and sometimes it's called metastatic calcification, because you do have specks of obviously calcium that just floats around in the serum. And so inflammatory tissue tends to attract that calcification a little bit more. You see that, in cystic breast tissues, you see that in other parts of the body which are inflamed. But the process more specifically in the coronary arteries, the deposition of most of that calcium is not just this metastatic calcification. It's actually you have osteoblasts. The same cells are creating bone in your bones. Osteoblasts are active inside the artery. They're bringing calcium, and those little guys are making like a little bone inside the artery. And so it's a very fascinating process. You're seeing bone formation there. And we now understand that when you look at people with a calcification, it's really trying to heal that area. I don't want to confuse everyone too much, but there are other things that we don't understand. In the MESA study, people who eat a lot of calcium, supplementation, right? Taking like Oscal or calcium vitamins, do have more calcification than typical in the arteries. However, these people do not have more heart attacks than others. So there's a little bit disconnect. And the other thing we see is like broccoli is high in calcium. But so if you eat a high calcium diet with dairy or broccoli or other things, we don't see this excess coronary calcification. It's really due to vitamin supplementation. And within the field, we tell a lot of women, especially, to take calcium supplementation to prevent hip fractures and osteoporosis. But I got to say that, and hopefully you guys know, like that has never borne out, right? People who take calcium supplementation don't actually have reduced hip fracture risk. So, and they actually have more kidney stone risk. So there's actually a hazard to telling people to take all this extra calcium supplement. I think we should emphasize high dietary calcium, but I'm very fearful of telling people to take calcium tabs. The other area that I tell people not to take calcium tabs is if they have early aortic valve stenosis. So valve stenosis is extra calcification. And we now have seen that if you have mild aortic stenosis, if you take calcium tabs, you actually cause faster progression of aortic stenosis that way. So again, I'm not saying I'm anti-calcium, just anti-calcium tabs in most people.
Okay. Thank you very much.
Yeah, you're welcome. Tanya asks, is calcium tests ordered by your doctor, or do you have to go to cardiology? So I have been encouraging my primary care referrers to go ahead and order the calcium score yourself. It just is like a little prescription, like you get a chest x-ray. FRC does it. I will say I love FRC, but they charge $250. But if you go to Reyes Radiology, it's $120. If you go to VHC, it's $96. and our Virginia Heart colleagues are going to charge about $99 to do it. So FRC is very expensive. So shop around. It's an out-of-pocket expense. Your insurances won't cover it yet. I think in 10 years they will start covering it, just like they cover colonoscopy or mammography, but we're not there yet. But the calcium score basically is the same cost as a cholesterol panel. So I think it's well worth the money. And I think if you score 0, you're good for 5 years, and you can rescreen every 5 years after that till you turn positive. The national guidelines by the AHA and the ACC now say if you have high cholesterol but a 0 calcium score, it is reasonable not to take a statin, because if you have a 0 calcium score, your risk of an event is so low that the statin is really not that beneficial, right? The number need to treat in a 0 calcium score population is so high, it's not worth it, right? But as I told you with my nurse, having 0 calcium score doesn't, exclude you from having a weird zebra like a SCAD event. And we don't have any great predictive tools for SCAD at this point. So, okay. And Jackie asked, does shock lithotripsy cause as much damage as burr? I think shock lithotripsy is a newer technology. It's just, I think we've been doing it for about maybe a little year and a half. I don't know exactly how much damage it has to the vascular wall compared to burr. I just haven't done it. I haven't done it myself. So that's a great question. I don't know the answer to that though. Okay, so let's just go on. I know it's 40 minutes after. So this highlights what I was talking about EKG placement. So this is a normal EKG, okay? But look at this EKG. So this is a very common thing. We actually see this a lot from pre-surgical testing. Here you see the V1, V2, V3, this little R wave should be larger and larger. And by V4, the R should be higher than the S, should be net positive. But when you see this weird progression, the computer will read this as a possible anterior infarction. And why this happens is because if you put V2, V3, V4 in the wrong position, it changes how that R wave is progressing, and the computer gets confused, and then they'll say like possible anterior infarction, and then this person has to go to see cardiology before their like routine elective surgery. So this is very common. And if I see a possible anterior infarction in a young woman who otherwise has no history of coronary disease and no angina, first thing I say is repeat the EKG and make sure it's, the leads are underneath the breast. So this is what we see a lot. Okay. So let's go through some cases and see. Okay. So case number 1, Miss Kim is 59 years old and she's admitted for an elective lap chole. She's post-op day 2. She wakes up with some chest pain. Vital signs, she's AFib about 98.5. She's slightly bradycardic at 55. Blood pressure is 118 over 75, and the respiratory rate is 16. And she's setting 100% room air. So you call a hospice to report the symptoms. And let me just do this, that she's having chest pain, and they order an EKG. Okay, so let's see the EKG. Here's the EKG. So I'll give everyone, and then I'm going to launch a poll. Let's see here. Let me just, sorry, I'm deleting some of the questions so that we can get it done. Okay, so let me launch the poll, and you tell me, what do you think you see here? Do you see the poll? Francis, do you see the poll? Okay. Okay, there are 14 people, so let's at least get a quorum. All right, we got 4 people. All right, waiting for a couple more people, so we at least get 50% answer. It's anonymous, so Can't be embarrassed. All right. Okay, gonna end the poll. Great, thank you. Oh, 9 people answered, right? Okay, so we got 9 people, and wow, it's evenly split between anterior STEMI, lateral STEMI, and inferior STEMI. So what this is a inferior STEMI. So we're seeing SC7 elevation in leads 2, 3, and AVF. So these are the inferior leads. So these are the leads that represent the backside part of the heart, which is usually supplied by the RCA. Okay. An anterior infarction would be if you see SCM elevations in V1 through V4. And a lateral SC elevation would be seeing SC elevations in V5, V6. Because remember, V5, V6 is over here, right underneath the armpit. That's the lateral. And then 1 and AVL would be lateral as well. Okay. Okay, so this is usually, here's another example. Sorry, this is more subtle, but this is you see the subtle SC elevations here. So anything more than 1 millimeter and 2 contiguous leads would be considered criteria for SC7 elevation. So about 40 to 45% of all heart attacks are due to the inferior wall being infarcted. And about 80% of the time, it's due to the right coronary artery being the culprit lesion. The other 20% is the circumflex artery in some people is really big and can go all the way to the back and can really supply the back wall. Okay, so that's, but 80% of the time, if you see inferior SC elevation, we're thinking RCA. Okay, so, oops, sorry. And interesting enough, inferior infarctions are also associated with vagal stimulation, which causes bradycardia, nausea, vomiting. So if someone's vomiting quite a bit and they're bradycardic, that's another symptom of a possible inferior infarction. And so here's a cross section of what that would look like. So here you see the muscular LV. You see the area being infarcted. This is inferior wall here. This part of the wall. Do you see my cursor, by the way? I'm not sure. Do you see my cursor? Okay, good. This is to the posterior wall. And admit, like, I was a cardiology fellow before I realized the posterior wall, the inferior wall were different things. I used to use them interchangeably. I thought that's the same thing, but they're slightly different. So this is inferior wall. This is the posterior wall, or technically we called it the inferolateral wall. So you may not know this, but in cardiology, we divide the LV into 17 segments. We call it the 17 segment models. So we give each area a specific name. So this would be considered mid-inferior. This would be mid-inferior lateral or the mid-posterior wall. This is the anterolateral wall. This is the anterior wall. This section here of the septum is called the anteroseptum. And then we divide the septum into 2 parts. And then this is the inferoseptum because it's next to the inferior wall. So probably more than you ever wanted to know about, LV, but that's how we do it. All right, so let's go on. So next question. So what would be the next appropriate management of this patient? Would it be to give sublingual nitroglycerin, start a heparin drip? Would it be to check a stat echo, activate the cath lab, or give the person some beta blocker, metoprolol? So let me launch the poll. Sorry. Let me see if it, okay. Oh, sorry. Okay. Hopefully you guys can see it.
What was the blood pressure again?
We'll say it was normal.
Okay.
Okay, we're getting good response. Maybe get one more for 10. All right. Okay, good job, guys. Okay, so the majority said activate the cath lab. 3 people said give sublingual nitro. 1 person get a stat echo. Let me share. You can see the results. Okay, so the correct answer is activate the cath lab. If you see ST elevation on an EKG, call the cardiac access, get the cath lab activated pronto. So giving sublingual nitroglycerin, particularly with inferior infarction, is potentially dangerous because the inferior wall is usually supplied by the right coronary artery. And as I said earlier, the right coronary artery can sometimes also infarct the RV. And the RV is very preload dependent. So if you give someone nitroglycerin in that situation, the RV would lose the preload and you can create very bad shock with that. So I'm not saying every inferior infarction has it, but if you see that, you should really avoid giving sublingual nitroglycerin. The next question is like, well, how do you check if their RV is infarcted? That's when you do the right lead EKG. You take the V4 lead and you put it underneath the right side. So that's the RV4 lead. And you're looking for at least 0.5 millimeter elevation there. You could do whole like right-sided leads, but that's actually not necessary. But if you just take the RV4 and you look for it, you can rule out RV infarction that way. But by and large, I would say if you're seeing inferior infarction, just avoid nitroglycerin. A stat echo, yeah, would be not indicating this because you really got to get that patient in the cath lab and it might just slow down the whole process. If someone's got a butterfly or can do POCUS, of course, like it's great to get the information as long as it doesn't slow down the cath lab activation. Again, starting heparin drip, isn't necessarily wrong, and you can certainly activate the cath lab. And if you have a heparin bag ready to go, sometimes you can do that. But we are so good at Fairfax, especially of getting people in the cath lab, that most interventionists would rather access the radar artery without the person on heparin right at that time anyways. And certainly when they go in, they'll give a heparin bolus as soon as they get access. So, and then giving metoprolol, no one answered that. So, in the ER, sometimes we do ask to give beta blocker, but the beta blocker data prior to cath was actually relatively weak in our large studies. So we generally have not been giving beta blocker upstream of the cath. So, all right. So most people got that correct. Great job. Okay. Let me see, close this. Okay. So again, you want to activate the cath lab, don't give nitro. And then, so this is a good example of what it may look like, where you see the RCA here, and then there's complete obstruction. And then this is a post image showing that the interventionist is able to get flow to the PDA. And there's an arrow here. This is some blushing here. But this is actually really due to the coronary sinus. So that's nothing too bad. Other medical management for ACS is aspirin, dual antiplatelet therapy. It's controversial, 3, 6, 12 months. Usually we're doing for 6 months now. If it's an acute MI, usually we use Effient or Brilinta. Plavix still is good. Just be aware, Brilinta and about 10% of the population can create shortness of breath. So I warn people if they're on Brilinta and they feel short of breath a couple days afterwards to let the doctor know so they can switch them to either Plavix or Effient. Brilinta is also more expensive. Effient is generic, as is Plavix is generic as well. All patients should be on high dose atorvastatin. And they should be on some beta blocker afterwards. The guidelines say beta blocker forever. I actually only use beta blocker for about 3 to 5 years after a STEMI or NSTEMI. If they're doing well after that, and if they don't have any heart failure and normal ejection fraction, it's safe enough to take them off beta blocker actually. Okay, here's another case. Mr. Jackson, he's 72, COPD, smoking, diabetic. So a lot of risk factors for cardiovascular disease, comes to cellulitis, started IV antibiotics. After dinner, he develops like 7 out of 10 substernal chest pain. He feels really short of breath. He says he didn't feel this before. Vital signs are actually okay. I mean, he's afebrile, heart rate 65. maybe a little borderline hypertensive, 132/85. But he's respirating good 16 times, 99% room air. The house MD is paged and EKG is ordered. So we see an EKG here. Okay, so this is normal sinus rhythm. We're seeing P waves. We see a right bundle branch block. And the right bundle causes these deep T waves. So if you see the right bundle, these T wave inversions are not dangerous or they're not abnormal. This is what you expect with the right bundle. And then the lateral leads, we see maybe a little SC cement depression, but nothing too crazy. Here, this is not SC cement elevation. This is the right bundle in the inferior leads. But suffice to say, there's no change compared to prior. So in this case, high sensitive troponins are ordered. Telemetry is started. Patient's given aspirin. He gets sublingual nitroglycerin, but doesn't really change the pain. So I just want to highlight our high sensitive troponin algorithm because this came out in December of 2022. I think most people are at this point are familiar with it. But, if they show up to the ER and the chest pain is occurring for more than 3 hours, if the first high sensitive troponin is very normal, like less than 5, that person rules out already. We don't even have to do a delta troponin on that person. But on the inpatient side, obviously, you're seeing these patients way sooner than 3 hours of their event. So here we divide it to less than 64 or more than 64. And if it's less than 64, you check a delta troponin. And if there's no significant change, then that person is low risk and they can rule out. And so in this person, the first initial troponin is 12. He gets some famotidine. An hour later, the chest pain resolves. 2 hours after that, the delta troponin is only 14, or a delta of only 2. And so acute MI is ruled out. So high sensitive troponins are very powerful. Because they're so sensitive, this algorithm is trying to take advantage of that and having a faster rule out. So we don't have to do like 3 troponins 6 hours apart, and you can check the troponins closer together. I will also highlight that men and women have slightly different thresholds, and women have a lower threshold of abnormality. So, and I will also say sometimes if the troponins are elevated in women, it doesn't necessarily mean that, they're having an acute heart attack. It could be another process. We've seen it elevated due to stroke. We've seen it elevated, obviously, due to arrhythmias. So there are other things that can create an elevated troponin. So, but, this has been a great tool. And I think when we first got it, we thought we'd be overdiagnosing heart attacks. But in actuality, I think it's been a really good tool for us to better define acute coronary syndrome. So, okay, so here's another case. So Miss Johnson had a hip replacement and she was doing well, but then she rings a bell because she complained like really severe sudden shortness of breath. You check vitals. She's tachycardic to 152. Blood pressure is about 109/72, and the respiration rate 18 with 95% of room air. The ortho resident's contacted and orders an EKG. This is what we see here. So, does anybody? So let me. I was gonna relaunch a poll, but we're running out of time. So, does anyone feel brave enough to say what they think this is? Okay, this is AFib with rapid ventricular response. Okay, so I was gonna quiz y'all, but so what is AFib? So AFib is a disorganized rhythm, multiple areas of the heart firing, almost like multiple storm clouds, okay, that just overtake the heart. And it's a slightly different rhythm than A flutter, which A flutter is a circuit that usually spins as a big circle in the right atrium. And another arrhythmia that we see is called AVNRT, which is a smaller spinning circle right around the AV node. Atrial fibrillation is common. I mean, especially in people over 70, 80, the majority of the time, if someone is in an tachycardia, it's irregular, it's going to be due to atrial fibrillation. So how do you handle this? So This comes from our AHA ACLS guidance for adult tachycardia with a pulse, because this person had a pulse, has a blood pressure, right? You want to oxygenate them if they're hypoxic. You want to put them on a heart monitor, get IV access. If they're persistently tachycardic, the indications for a emergent shock would be hypotension, altered mental status, signs of shock, ongoing ischemic chest pain, or really bad acute heart failure. Okay. But in the absence of that, you can take your time to try to rate control. So if it's stable AFib with RVR, generally we use metoprolol or diltiazem. Dilt is good because you can use it in a drip form, but there is short-acting versions. I still believe in the benefits of digoxin, especially if the person has kind of a borderline blood pressure. DIG doesn't work fast, but DIG is really, really good for people who have severe AFib that just is really hard to rate control. And you're kind of at your max dose of metoprolol or DILT because of blood pressure issues. These people should be started on anticoagulation orally if their CHA2DS2-VASc score is more than 2. We should check an echocardiogram. And you can consider T and cardioversion if there's inpatient persistently in AFib RVR despite medical therapy. So this person was started on DILT initially at 5 an hour, but after 3 hours, she's still tachycardic, so the drip was increased to 10. And cardiology asked ortho, hey, can she get Eliquis? Yes. And then this, we often see the patient's kind of sleeping and they're in rapid AFib. You see a little conversion pause, and then they go into sinus. And next week, we'll talk more about telemetry. So we'll go over some telemetry cases next week, okay? So in the morning, it's a happy story. The echo shows a normal EF, just a mild mitral regurgitation, mild LA dilation. So she can come off the DILT drip. She's started on oral DILT, and she can go on outpatient stress test and follow up. In this last minute, so I just want to highlight, like, it could go the other way. She could have been starting a DILT drip, but then she's still a tachycardic. They increase the drip. She becomes hypotensive, and then they have to decrease the DILT drip, which makes her more tachycardic. So an RRT is called. At this point, the blood pressure is lower, and she's feeling more chest pain, more shortness of breath, and she's becoming hypoxic. So she's slipping into some acute heart failure. So under these circumstances, this would be an indication to do a urgent cardioversion at the bedside with sedation. This doesn't happen very often, and I'm sure in your experience, this doesn't happen, but theoretically it could. But this would be where you veer off to do something sooner. So I know we're at 6 o'clock now, so I think I'm just going to stop and give some time for any final questions. There's so many different cardiac issues, but more importantly, I just wanted to give you some basic physiology, basic anatomy to refresh everyone, and also give a framework to how to plug these problems into one of 4 areas, right? It's either a problem with the pipes, the electricity, the valves, or the muscle usually, okay? And if you keep that in mind, I think that helps kind of your management.
So Dr. Tran, thank you so much for taking time from your busy day to share your knowledge and expertise. I think you have a knack and a way of explaining things that make sense.
Great.
And really do appreciate it. I started recording after kind of the introduction, so we'll at least have a cloud record that I can send out to folks so that they can also review it. So appreciate your time, and thanks everybody for attending. As Dr. Tran mentioned, we're going to do another one on telemetry and some of those strips. So we'll make sure that we get that information sent out to everybody.
Yep, we'll do it next week, same time. So hope to see you next week. Again, thank you so much for your participation and attention.